I declare open this hearing of the Senate Select Committee on COVID-19, and I acknowledge the Ngunnawal and Ngambri peoples who are the traditional custodians of the Canberra area and pay respects to the elders past and present of all Australia's Indigenous peoples. Today's public hearing will focus on vaccinations largely, but may cover other matters under the terms of reference. Information on the procedural rules governing public hearings has been provided to all the witnesses and is available from the Secretariat. If a witness objects to answering a question, the witness should explain the basis for the objection in sufficient detail to allow the committee to determine whether to accept the objection. The committee will then decide whether to insist on an answer. Witnesses may request that answers be given confidentially. I remind those on video conference to mute their microphones when they're not speaking, and please ensure mobile phones are switched off or turned to silent. I now welcome the Secretary of the Department of Health, Dr. Brendan Murphy, the Chief Medical Officer, Professor Paul Kelly, the Coordinator General of the National COVID Vaccine Task Force, General John Fruin, the Australian Technical Advisory Group on Immunisation, and other good officers of the Department of Health, including the Therapeutic Goods Administration. Now, to my colleagues on the committee, Professor Kelly and General Fruin will be available for the first hour of today's hearing, so until 1 p.m. And I understand, before I start going to questions, we have opening statements from both Professor Kelly and General Fruin. So I'll hand to you guys to select the order for which you do that, and then we'll proceed to questions. Thank you.
Thank you, Senator. General Fruin will go first and then Professor Kelly.
Thank you.
Thank you, Chair. Good morning, and thank you for the opportunity to make a brief opening statement. I would like to start by acknowledging the traditional owners of the land on which we meet and pay my respects to elders past and present. I am pleased to report that the National Vaccine Program has made significant progress since I last appeared before this committee. Australia is now approaching 90% fully vaccinated, and we are becoming one of the most vaccinated countries in the world. 93% of Australians aged 16 years and older have now received a first dose of a vaccination, and 88.3% are fully vaccinated. All states and territories have reached 70% fully vaccinated, and all states will reach 80% fully vaccinated this month. We have administered almost 40 million doses through over 10,000 points of presence. We are also managing our supply, including through donations to the Pacific and Southeast Asia, and have donated over 9.3 million doses to date. I'm pleased the gap in vaccination rates for Indigenous Australians has reduced to less than 18%. This is great progress since the Accelerating Indigenous Vaccination Plan was announced, when on 14 September, only 38.9% of Indigenous Australians had received a first dose and 22.4% were fully vaccinated. Now, 75.5% of Indigenous Australians have received at least one dose, and 64.9% are fully vaccinated. I want to acknowledge the ARCHOs, the communities, states and territories, and service providers who have worked in partnership with me on this priority. It is this partnership that has driven these results. I was fortunate to see this during a recent visit to Dubbo, where, as a result of this partnership, Indigenous vaccination rates lifted to over 84.6% first dose and 80.7% fully vaccinated. I'd like to acknowledge Phil Naden from the Aboriginal Medical Service, Chairperson Anne Dennis of the New South Wales Aboriginal Land Council, Superintendent Danny Sullivan of the Regional Emergency Operations Centre, and the National Indigenous Australian Agency, Dubbo Regional Council and New South Wales Health for showing me how this partnership works in practice. Work continues to improve rates of vaccination for people with disability. NDIS participants are now 83.5% first dose and 78.6% fully vaccinated. I have been working with the COVID Disability Advisory Committee to improve our efforts and increase transparency in the rollout for people with disability. I would like to put on record my appreciation for the frank advice and guidance the committee has provided me, particularly Jim Simpson from the Council for Intellectual Disability, who has organised and supported this engagement. Our booster program has commenced, and I'm pleased to report that 470,000 people in Australia have received a booster or third dose. As per the ATAGI advice, you are eligible for a booster if 6 months has passed since the completion of your primary course. We are strongly encouraging eligible people to come forward and take up their booster to maintain the strong levels of protection we have built across Australia. A national mail-out has commenced informing households about the booster program, raising awareness of the increased protection booster vaccinations provide the Australian public. A communications campaign has been developed to support the booster rollout that includes an advertising campaign and specific communication efforts. All participating primary care vaccination sites, including general practices, are able to administer booster doses. To ensure that sufficient Pfizer vaccines are available in every state and territory to support access to boosters, we are facilitating Pfizer doses to participating pharmacies across Australia. I am particularly focused on ensuring booster clinics are being offered to residential aged care facilities and shared disability accommodation sites, and over 800 booster clinics have already been delivered to this cohort. Finally, I'm working closely with states and territories on planning for the rollout of vaccinations to 5 to 11-year-old children. The TGA has provisionally approved Pfizer for 5 to 11-year-old children, and subject to a target advice, this will commence in early January. I'm working with the states and territories on the allocation of doses. We anticipate that GPs and community pharmacies will primarily be responsible for vaccinating this cohort. However, welcome the participation with states and territories as we aim to vaccinate as many children as early as possible in 2022. Thank you again for the opportunity to make this statement, and I look forward to your questions.
Thank you, General Fruin. Professor Kelly?
Thank you, Senator Gallagher, and good afternoon to everyone online. I'm sure that there'll be a lot of questions about the Omicron variant, so I thought I'd start with an opening statement to set the scene for those questions and hopefully answer many of those questions right up front. So the Omicron variant was first identified in South Africa on the 23rd of November 2021, which I will remind you was only a little over a week ago. By definition, Omicron differs from past variants of the SARS-CoV-2 virus, but it's very important to understand this is the same virus we've been dealing with since the start of the pandemic. What we must remember is that there have been, during that period since late 2019, many thousands, tens of thousands of variants. It's the evolutionary forces that push viruses to change in this way and to develop mutations that assist them to transmit between people. But not all variants are worrying. Many gain no advantage through their mutation and exhaust themselves in very small numbers, sometimes with only one person showing that particular variant. Omicron includes several changes or mutations, including in the spike protein, which is the main reason it has been classified by the World Health Organization as a variant of concern on the 26th of November. Variants of concern are named for letters of the Greek alphabet. This is the 13th such variant. So that has been named by WHO. Not all of those have been variants of concern, I must add. In a sign of things to come, the WHO has indicated once it has exhausted the Greek alphabet, they've got 11 left, it will look to stars and constellations for future names. It is clear that this will not be the last variant that we will be dealing with. Variants of concern are declared once they have been detected because of their potential to impact on human health. The three areas we focus on are severity, transmissibility, and interference with vaccines and treatments. So firstly, on transmissibility, the ability to pass from person to person, otherwise known as infectiousness. There are indications that this new variant is more transmissible, or at least as transmissible as the Delta variant. Research is underway to understand if this is due to the variant itself or to other factors, which I'll allude to shortly. What about severity? In terms of severity, at this stage we have no definite signals anywhere in the world that the Omicron is more severe than any other of the variants that have preceded it. Of course, we're watching that very carefully. It's very new in its evolution and understanding, and so that is an open question. Partners around the world are working together to understand the potential impact of this variant on our existing countermeasures, including vaccines, but also treatments. So some of the treatments, such as corticosteroids and IL-6 receptor blockers, and at least some of the antiviral therapies will still be effective for managing patients with severe COVID-19. They have a different mechanism of working, and it's irrespective of how the spike protein may look in a particular variant. Investigations in regards to vaccine effectiveness are continuing. We expect to have more information, including from Australian laboratory scientists, during this week. There does, however, appeared to be anecdotal evidence of reinfection with Omicron that is occurring. And in fact, there was a paper that was published online today from South Africa, which also supports that possibility. I understand that these changes may be worrying news for some Australians, but I want to give you reassurance about how well prepared Australia is and how we are responding. While we still need to learn much more about Omicron, the amount of information we are seeking and receiving from our partners around the world is significant. Within the department, we've stood up a rapid risk assessment team within the National Incident Centre, which is providing daily updates on the current situation and what we know about this variant. As a part of our information gathering, we have met with a range of international counterparts to discuss the emergence of Omicron, public health responses and border controls. In the past week, either myself or members of my team have met with the World Health Organization, the European Centre for Disease Prevention and Control, representatives from the governments of Israel, Spain, Japan and South Africa. These meetings have provided insights into the epidemiology of the Omicron variant, the severity of the variant and implications for health systems. These international comparisons have been considered through the development of Australia's response to the variant. In terms of our own experience here in Australia, Omicron is already here, and as it has spread around the world in the past 10 days. There are now 49 countries that have recorded over 1,000 cases of Omicron, and this is likely to be an underestimate. Genetic analysis tells us Omicron is likely to have been circulating in southern Africa undetected and unidentified for several weeks, possibly as early as September. As I said, we already have Omicron here in Australia. As of just a few minutes ago, I can confirm there are 37 identified cases detected in Australia, of which only 10 were associated with overseas travel. The rest are locally acquired. In terms of our response here, we took rapid measures, and the measures imposed early at our international border are managing the bulk of the risk of this variant, giving us the time to learn more about it. To be very clear, we are not looking to stop the entry of this variant, but rather looking to slow down its transmission into and within Australia as we have time to learn as much about it as we can to guide our ongoing public health response. This approach has been endorsed by both the Australian Government and the National Cabinet. Currently, incoming travel for non-Australians who have been in certain African countries in the past 14 days is not permitted. So there are 8 countries involved in the southern tip of Africa: South Africa, Namibia, Zimbabwe, Botswana, Lesotho, Eswatini, Malawi and Mozambique. Australian citizens and permanent residents, immediate family members, including parents arriving from these locations, will need to immediately enter supervised quarantine for 14 days, subject to jurisdictional arrangements. Anyone who has already arrived in Australia prior to these announcements the weekend before last, and who has been in any of those 8 countries in the previous 14 days, must immediately isolate themselves and get tested for COVID-19 and follow jurisdictional quarantine requirements. And we've assisted the states and territories, particularly Victoria, New South Wales and ACT, to identify and to make sure they were in contact with all people in that regard. The government has also suspended all flights from the 8 southern African countries for a period of 14 days as a matter of precaution. Globally, many countries have responded by imposing travel restrictions and additional public health measures on travellers entering from specified countries, including South Africa, most that same group that I mentioned. New Zealand has taken several similar steps, so has the UK, the US and Canada. Others have gone further. What Australians can do, I would first say that I have every confidence that the systems and processes Australia has built to manage this same virus and in all of its variants over the past 2 years are sound. Our public health, laboratory and clinical care systems are the backbone of our response, and they serve Australia well. These are the systems, the procedures we have relied upon to keep us safe, and they are still up to the task. Australia remains in a good position to respond to any COVID-19 variant. General Fruin has already mentioned where we're up to in our vaccine rollout. We encourage, of course, and I would join the General as well, encouraging anyone to come forward who has not yet been vaccinated. Now is the time. Or if you're due for your booster shot, do not delay. It's also time that we continue to learn, as we continue to learn about Omicron, to remember the basics which have helped us through the first 2 years of the COVID-19 pandemic. And these are still practices we should be undertaking. Good hand washing, cough and sneeze hygiene, physical distancing, staying at home if you're unwell, get tested if you're unwell, wear a mask when asked to do so, or indeed in circumstances where physical distancing may be difficult, or whenever anyone would feel safer wearing a mask. Thank you for your indulgence, Chair.
Thank you very much, Professor Kelly, for that. That's very informative and useful information for the committee. So we've got 45 minutes before you have to leave and General Fruin has to leave. So if
I think they can stay a bit longer, Senator, if necessary. Yeah.
Oh, okay.
Yeah.
Don't invite us.
But we always wish to meet the needs of
understood.
So,
well,
yeah.
we even shifted our break to facilitate that. So anyway, we'll see how we go. We know everyone's really busy. So colleagues, if you can just maybe we'll have longer with other officials. So if you have things outside of the vaccine rollout and probably the advice around Omicron, hold that for later and we'll get the call going around. General Fruin, can I start with you? How many Australians are currently due for their booster? Do you have that information? How many people would be now falling in that 6 months?
Yes, I do, Chair.
Yeah.
So this is in the over 16s. As of today, it's 678,154 people eligible for a booster.
Okay, and when does that, so, and you're saying that you've 470,000 of those, are they you can't actually probably make that just a subset of that, can you? But what
as at today, we've had 559,046 who have received a third dose or a booster.
So it's a pretty high level of return there, you're seeing?
Yeah.
Do you have that in a percentage figure? What would that be? It's all right, I'll work it out later. And presume over the next 2 months, 2 to 3 months, you'll see a big increase in the numbers of people becoming eligible for their booster shot?
The number starts to rise. The really large numbers occur in March, April and May next year.
Okay.
By the end of the year, at the end of December, we'll have 1.75 million people due.
Okay.
By the end of January, we'll have 4.11 million due. And then it goes on, as I said, till by the end of May, the 26th of May, it's 17.85 million. So it starts to ramp up dramatically through March, April, May.
So there's a big vaccination effort required again in the first half of next year. Are there any changes planned to how you're rolling it out, or are you going to maintain pharmacies, GPs, state and territory clinics?
Yeah, so we certainly think primary care will remain the backbone of the program, but we are in constant negotiations with states and territories as to what particular role the states and territories will play. I think there will be some adjustment to the way the states and the territories interact, because you might recall, through, say, the large outbreaks in New South Wales and Victoria, there were large mass vaccination clinics that were established. They may play a part in the states or they may not, but that's work still in progress. But we are absolutely planning for primary care to remain the fundamental set of pathways.
Okay. And in that, you mentioned that you were being focused on residential aged care facilities and shared disability accommodation sites. Do they form the majority of the ones who've had the boosters to date? Because I would imagine
at the moment, it's predominantly all of those people who were in the 1 alpha categories, frontline health workers and the like, but there are aged care facilities in particular. There's a large number of those, and there are also a number of disability facilities as well. I can give you the numbers on the facilities that we are already servicing. So already there are 1,861 residential aged care facilities who are eligible for boosting. We have done 789 of those have already received their boosters. We've got another 977 that are scheduled before the end of the year, but are not yet, haven't yet had the visits. There's another 58 that will be doing self-vaccination. And there are another 37 that are either yet to clarify exactly what their preference is, or there's 19 of them who have asked to have the clinics delayed until 2022. In the disability space, there is 899 settings that are eligible for boosters now. We've contacted 830 of those so far. 552 of those are complete or scheduled, and the others, similarly, we're working through particular pathways, what their preferences are and the like. So the aged care facilities and the disability facilities that are due, we have already done a lot of work and have a plan to get the vast majority of them done this calendar year.
Okay, so for someone, an aged care resident, I tried to take down those numbers, but there was a lot of them.
Okay.
So for an aged care resident who's due their shot, do you have an end date to when, acknowledging that people's shots will be coming due at different points in time, but for the vast majority of those in the 1A category, do you know what's your plan for when those vaccinations will be complete?
Yeah, so as a facility is 6 months since their second dose visit, we are planning to have an in-reach visit, or if the facility prefers to do self-vaccination, or there's a primary care visit is preferable. As they become eligible, we are ensuring that we have got arrangements in place for them to receive either in-reach or to be linked up with another type of provider.
But within that, is it sort of at the 6 month mark, or will it take 8 months to?
Yeah, we're offering it at the 6 month at the moment, and as I've just mentioned there are, for example, 19 aged care facilities that have asked to schedule it in the new year, which will be a bit after their 6 month period, but because of the Christmas period and workers going on leave and those sorts of things, their preference was. But we are working to get it as close to the 6 month as possible. But if it isn't, in and around the 6 months, it might be a month or so after. But at the moment, the vast majority are taking it up pretty close to the 6 months right now.
Okay. And on supply, is there any issues around supply of vaccine for the first half of next year in terms of providing the boosters?
There are absolutely no issues with supply.
Yep. So what does that mean? You've got more than enough?
We have got vastly more than enough, Chair, and so there isn't any concern with the ability to provide boosters as people come due throughout the first half of next year. And we also are working, wherever we have got excess supply, that we are working with DFAT to move, at the moment, primarily AstraZeneca, but we're now looking at options for the donation of mRNA vaccines out into the regional Pacific and Southeast Asia as well. Okay,
so is that where we've got too much for what we need now and you don't want it to expire and be wasted?
Yeah. So we're managing that in a number of ways. We're still doing management to make sure that doses that are nearing expiry are being used first. We are working to donate if that's appropriate. We have also delayed some deliveries of mRNA vaccines from overseas to make sure that we haven't got vaccines here that are, the clock has started ticking on for expiry as well. So It's we're working that one very closely as well.
Have we had much wastage to date of vaccines?
Yep. So Throughout much of the program, the wastage rates were running at a remarkably low, around about 1.2%. At the moment, the wastage rates have crept up to 4.32%. The primary reasons that wastage have gone up at the moment are there was a lot of vaccine that was brought forward around the time of the outbreaks in New South Wales and Victoria. So some of those doses have reached expiry date. There is an issue with Moderna, that Moderna is a 10-dose vial, and we have put in place a different risk setting around the use of vaccines now. During the early stages of the program, when every dose was precious, we were making sure that no vial was opened until we had enough people. Now we are saying if you have got a person who needs to be vaccinated, that you should open a vial. In the pharmacies with the Moderna vials, that means sometimes a vial is being opened when they've only got one walk-in, and then they might not get any more walk-ins for the rest of the day, so you waste 9 of the 10 doses. But we are watching that wastage rate very carefully as well. The OECD average at the moment for wastage in comparable programs is between 10 to 15%. So even though it has crept up, it is still a very good level from a program management perspective.
Yeah. So do you have the dose number of what that 4.3%?
Yep, that is 3.052 million.
2 million, okay. Thank you. I know others have got questions. I just have a few around children. So we know there's going to be a rollout. I think the 10th of January seems to be the date that the government is saying. How many children will fall within the 5 to 11 category?
The 5 to 11 category will bring in 2.3 million children.
Yep. Okay, and how long do you think that will take to, based on what you know about how the vaccine rollouts occur, particularly in the 12 to 15, how long do you think it will take to get the vaccine rolled out to that many children?
So you'd be aware the TGA has given their provisional approval. We are waiting for the ATAGI advice.
Yeah.
We are in negotiations with Pfizer now and believe we will have adequate supply early in the new year to cover the entire cohort. If everything is in place, we're planning to commence the rollout for 5 to 11-year-olds from early January. And we will be seeking to offer every child in that cohort the opportunity for a first dose vaccination, ideally before the commencement of the school year next year. We think at the moment we will have the doses available. We think we have got the pathways open. We are working with the states and territories about what particular arrangements they might wish to put in place around things like school-based vaccination, for example. But at the moment, we think we will have the capacity to get all of that cohort first dosed very early in the new year.
Okay, so the paediatric doses are ordered, but they're not here as yet. Is that correct?
That's correct.
Okay.
Yep.
And do you have I understand that all the approvals aren't yet provided, but I'm presuming you're having to do a lot of the kind of the infrastructure preparedness now, pending that approval.
Yep.
So is that a deliberate decision not to have the vaccine here, in late December, ready to go in January, or is it more availability of the paediatric vaccine by Pfizer? Are we dependent on them being able to deliver that to successfully roll it out in January?
So, Senator, we couldn't obviously take delivery until we had TGA approval. That's only just been...
Yeah, I said late December. Yeah.
Yeah, so and we have been working with Pfizer, though, over the last few months, and we will be one of the earliest countries to get those paediatric doses after the US, and so they're confident that they can get sufficient doses to us in late December to enable, as the General said, to offer everyone a first dose early next year. So it was a combination of the TGA then have to test the batches when they come, and we have to get the ATAGI advice, as the General has said. So all the stars are aligning very nicely. And obviously once we've got the doses, we will have to pre-deploy, we'll have to run training programs for the GPs and the pharmacists, because it's a different formulation, all that sort of stuff. So it's all done as quickly as we could get the possible after the TGA, and then the ATAGI advice, which we're expecting fairly soon.
Okay, we might go to ATAGI a bit later because I'm just conscious of people's time. But how realistic is it in the Christmas sort of, holiday period, do you think, to train all the people you're going to need to train and have the appointments ready and to get it done before school goes back? I accept that's the ideal, but is it realistic?
Yeah, no, look, in terms of the two key steps for us are once we've got the ATAGI advice, we will have the training package in place. It's largely a web-based training package. And also then there will be the accreditation of the vaccines when they arrive. TGA have assured us that they will be available over the period to do the checking of the vaccines. So that part of it is fine. Once then we get all of that in place, we will then commence the program in as early as possible in January. At the moment, we're working on an approximate date from around the 10th of January. Yes, it's a difficult time of the year, but people will have the opportunity then in the latter part of January to get their kids through all of the pathways available. Okay, and
again, I'll come back once I've shared the call. My final question to Professor Kelly. What can you say to Australian parents about the safety of the vaccine? I know I will go to TGA and to ATAGI, but I'm conscious that there is already misinformation being sent around the safety of the vaccine for 5 to 11-year-olds. Are you watching that, the misinformation, and two, what would you say to Australian parents considering getting a vaccine for their 5 to 11-year-old?
So you've directed that to me, Senator,
yes.
So I'll give a brief word, but I know that ATAGI Chair Chris Bly is on the
I'll go to
call.
them as well, don't worry.
Yeah, of course you will. So we were actually on a call with colleagues from US CDC today. I found that very reassuring. I'll be interested to hear. I haven't spoken to Chris after that, but they of course have already administered over 5 million doses to that same age group, and they reported on their experience with vaccine side effects, which generally are very minor and not unexpected. And the particular side effect that we are watching very carefully is the one that's been reported and has been amplified, as you say, by the misinformation campaign, is on myocarditis and pericarditis, inflammation of the heart or the surrounding of the heart. I was very reassured from that data that we got today that is an extremely rare event in that age group. So my message to Australian parents would be this is a really important component of the protection of your children. It also will allow other usual childhood events such as going to school, going to childcare, going to other parties and so forth, much safer. I will point out in that age group there have been, up to the 21st of November, 22,000 cases in that 5 to 11 age group, most of them not severe, but there have been 22,000 kids have been sick. So it is worthwhile, it's a worthwhile, safe and effective vaccine in that age group, and I would encourage everyone to take it up.
Thank you very much, Professor Kelly. Can I go to Senator Davey? And I'll just check, have we got another senator that's joined by teleconference?
Yeah, hi, Senator Rennick here as well.
Okay, Senator Rennick, are you seeking the call at some point?
Yeah, I would like a chance to ask some questions, please. Thank you.
All right, and do you have questions for General Fruin or Professor Kelly, because they are time limited?
Okay, Professor Kelly's fine.
Okay, all right, I'll come to you after I've been to Senator Lambie. Senator Davey.
Hi, thank you all for coming on and giving up your time. I appreciate that General Fruin and Professor Kelly have short time. I just want to come back to General Fruin. You were explaining about the rollout in aged care and disability residential services. And you said that you, in your conversations with the facilities, most are scheduled by the end of the year. Some have actually requested scheduling next year. Can you just clarify what the timeline is, what the advice is for when the booster should come? We've all heard it should be about 6 months after. Is there any problem if it's delayed, or why would some of these services be delaying your return?
So, Senator, Professor Paul Kelly, Chief Medical Officer here. I might just say a few words, but again, Chris Blythe, the ATAGI Chair, is on the call. Just on boosters, obviously, with the Omicron variant, people are interested to see what we can do and should do to boost our immunity. And boosters, of course, exactly do that. You know that ATAGI has examined this and continues to examine all elements of the booster policy and have been doing so for some months, guided by the best evidence as it's come, and it is all coming in real time now. So the current advice is for 6 months after the second dose of the vaccine in the primary course, shorter for those of us that have an immune deficiency, so that can be seen more as a third dose at 2 months or more after the second dose. But for the majority of the population, it's 6 months. We asked them specifically, I asked ATAGI, because they are our absolute experts in this field in Australia, to examine if there should be any change with the Omicron variant. And we had that announcement, I think it was last week, saying that no change for now. But I wonder if you would like to hear from the Chair himself.
Well, I think we're going to have ATAGI, so I'll ask him the same question to eat up your time. On that, at this stage, what we know, and Professor Kelly, you may have an opinion, we're still investigating how effective the existing vaccinations are with Omicron. Are we well placed if there needs to be an adjustment to the vaccinations or an update? Are we well positioned to be able to get access to doses of an Omicron effective vaccine?
Thank you, Senator. So, firstly, we don't know that we will need a specific vaccine. That currently there are several ways that we'll know whether the vaccines are effective. The first one we will know at the moment. All we have is a theoretical concern, as I mentioned in my opening statement, about the nature of the mutations on the new virus which affect the spike protein. We know that some of the areas of the spike protein is exactly what the vaccines are designed to create an immune response to stop that virus, and so a change there could theoretically cause the vaccines to be less effective. But we have no evidence at the moment of that from either laboratory, clinical or population health studies. In terms of the laboratory, that will be the quickest. As I mentioned, we have laboratory scientists already in Australia with the virus growing in the laboratory. They have all of the techniques available, equipment, etc., and the know-how to do those tests here in Australia. They're very linked in with other countries around the world who are doing similar tests. So within the next few days, I think we will have some preliminary advice based on those laboratory tests. After that, we really need to see what happens in the clinical sphere in hospitals around the world or in the population around the world to see whether the vaccines are fully effective, partially effective, or less than that. In the meantime, both Moderna and Pfizer, and indeed other companies, but particularly those two mRNA vaccine manufacturers who are licensed here in Australia by the TGA and we've been using right throughout the program, have announced that they can, and I suspect they already are, looking at changing that mRNA to be a more specific, specifically related to the new variant, and that can be done extremely quickly. Both of those companies have said that within 100 days they could have a product ready to go to market. Now, that would be longer, of course, to make the many millions of doses that would be required if it was required. But we have, we have pre-purchase agreements with both of those companies. The Secretary may be best to talk to those.
Yeah, thanks, Professor Kelly. So our pre-purchase agreements with Pfizer and Moderna, we have very large pre-purchases for next year and the following year. They all of those contracts do envisage that if a different vaccine is required, that those advanced purchase agreements cover that. So we would have rights to any new vaccine should it be required. And I do emphasise, as Professor Kelly said, that we simply don't know whether we will need a different vaccine until we get the data on Omicron with the current vaccines.
That is, though, quite reassuring that those existing agreements and our existing relationships will cover it if required.
Yeah.
Is that?
That is absolutely right. That's absolutely right. Yep.
Thank you. I just want to come back to a couple of things Professor Kelly said. You said that you'd stood up a rapid risk assessment on the new variant within the department. Is that new team, do you think they will remain in place as a rapid response unit going forward, given that we're now looking at going above and beyond the Greek alphabet, potentially?
So that was stood up within a day of this event. We planned for exactly this issue potentially happening. We had a framework, we had a template to fill in what sort of questions we needed to ask of whom, and all of those things were planned. It's a standing capacity within the National Incident Centre. So they'll keep going on that that cadence for the time being. There's so much more that we've learned in the last week that we didn't know the previous week, and I'm sure the next week will be similar. As long as it's required, it will be there. If another variant was to come up, and it's not an if, it's a when, then if it is a variant of concern, we will of course follow that similar procedure.
Great. And you also mentioned that you've been working at length with international agencies and working with health through both health and DFAT. Can you just walk through what countries we have engaged with and what we've been learning from their various responses and how our representatives at the WHO have been engaged?
Thank you. So we have an international branch here within the department, or division perhaps. I may have that nomenclature wrong. Actually we have staff permanently placed in Geneva because that's where the World Health Organization headquarters are. Through that branch, we're division rather, we're very linked in with international partners around the world. And in terms of WHO, whenever there is a meeting that our people on the ground are there, we often have people through the middle of the night here in Canberra also attending those meetings. When international travel allows, the previous Chief Medical Officer, for example, has attended those meetings once a year, the World Health Assembly. So we're very linked in with WHO, both at the global level, but also in our region through the Philippines office. Professor Murphy and I have had several meetings with the Director General at the Western Pacific Regional Office, and there's another one that's scheduled in the coming weeks with myself. Last night I had a direct meeting with an Australian who some of you may have heard on the radio over the weekend. She's one of the spokespeople for the World Health Organization, an Australian doctor, Dr. Margaret Harris. We worked through what they knew, and we talked about what we were planning and what they were planning. We've had similar meetings, as I said, with the European Centre for Disease Control and Prevention, and with Israel, Spain, Japan, and others. I think just to summarise what we learned from those meetings was, and it's a credit to the rapid assessment team, we didn't learn a lot. It was mostly what we already knew. It reassured us that we were across what was happening in that international sphere, but also that our approach was very similar to like-minded countries. The South African meeting that I mentioned, we actually had a 2-hour exchange of dialogue, a dialogue with an exchange of information and ideas with between our National Health and Medical Research Council and the South African equivalent. That was extremely useful. The paper I mentioned that was published today, they showed us the slides from that paper, the graphs and so forth from that paper last week. So we were some of the first people in the world to see that information about Omicron and how it was playing out in the South African setting. For their part, they were very interested in our very high vaccination rate. It's one of the challenges in South Africa that their vaccination rate is extremely low. We had a discussion and we made some presentations to them about vaccine hesitancy and how we've dealt with that, and also on the issue of mandating vaccines. So that's the summary, Senator.
Thank you very much. And I congratulate and commend everyone for getting our vaccination rate up. I remember a few months ago we were very concerned we wouldn't get there, but we've done well. Thank you, Chair.
Thank you, Senator Davey. Senator Lambie.
Thank you, Chair. I was just wondering if you'd be able to tell me the pharmacies, they get paid less to give a jab than what the GPs do. Is that going to change with the booster shot, or are you still expecting them to be doing it at the same price while GPs getting quite a substantial lot more?
So Senator, the rates for the GPs and pharmacists have been determined by government, and they're based on the second dose rates that both received in the primary vaccination rollout. The GP rate, I think, was originally set a little higher because of some of the complexities involved, but that's been a decision of government. There's no intention to change that differential rate.
So do you expect the pharmacies to put up their hands for the boosters as well with a reduced rate?
It's not a reduced rate, Senator. It's a rate that it's missing. They had a bonus, as we say, for doing 2 doses, but it's the same as the second dose rate. And Dr. Detoka might be able to add something to that.
No, that's what I'm asking you, Dr. Murphy. Do you expect that pharmacists will continue to take on this role if they're going to get paid for the booster the same as what they did for the others compared to the GPs? So if you're not going to do this, is this going to cause a problem with getting booster shots out there as quickly as you'd like?
Well, but the evidence is not suggesting that, Senator. The pharmacists have stepped up. This is the first time pharmacists have actually been paid to deliver immunisations. They used to deliver immunisations mostly based on the profit margin from the vaccine sales when they did private market vaccinations. So this is the first time they have been paid, and we are seeing great uptake by the pharmacies, and they are continuing to provide vaccinations.
So all those pharmacies have given you have given a guarantee that they will do that same. They will do it for the same pay for the booster as they did for the first and second shots.
Certainly, as we have not seen any evidence that pharmacists, I mean, I know there have been some commentary on the payment rate by some of the professional associations, but pharmacists have played a very significant role. They've stepped up, and as far as we can see, there is no issue with them continuing their role in boosters. I don't know whether Dr. Detoka would like to comment, because he's been directly involved with the pharmacists. Dr. Detoka?
Thank you, Secretary. Thank you, Senator. Dr. Lucas Atoka, First Assistant Secretary, Implementation and Primary Care Response in the National COVID Vaccine Task Force. Sorry for the mouthful. So as Professor Murphy indicated, we haven't seen any noticeable drop-off of pharmacy participation in the program. As Dr. Murphy said, the rates are equivalent to the payment structure that existed for the primary course as it is for GPs. And the payment that exists for a single dose without the complement for primary course completion is both what it's been applied for pharmacy rates at the pharmacy schedule and for the GP MBS reimbursement and the MBS schedule. Just over half of the participating pharmacies that are delivering Moderna have also put their hand up to and are delivering the Pfizer vaccine, and that was a change made to enable pharmacy boosters at the time at which, as it is now, Pfizer is the only vaccine currently approved by the TGA for the booster program. If TGA were to approve Moderna for boosters as well, that's the entire pharmacy network available to do so. And in fact, the proportion of daily vaccinations that have been undertaken at pharmacies compared to jurisdictional channels or GPs or others has increased in the recent weeks. So we're not seeing. We understand the concerns. We have heard the concerns from the professional bodies, as Professor Murphy indicated, but we are not seeing any noticeable either dropout or lack of participation from pharmacists in the program.
Thank you. So all the 460,000 people that have received their booster shot so far, that's a booster Pfizer shot, is that correct?
Correct, Senator. Pfizer is the only vaccine. Well, there might be some that have received, if they're not able to get Pfizer, they're able to get AstraZeneca or Moderna, but Pfizer is the only currently TGA approved booster.
Yeah. And off-label use as a non-preferred option of AstraZeneca for people who had a primary course of AstraZeneca without any major issue is also contemplated in the TAGI advice, but the preferred vaccine for use in the booster program at the moment, and the only one that is TGA approved for that purpose, is Pfizer.
Should we shorten the time frame between people's second shots and boosters?
So that's a question that ATAGI is actively considering, and you may wish to ask the ATAGI co-chairs to address that, Senator, because that's something that they're reviewing on an active basis every week at their meetings. If you'd like to get Professor Cheng or Professor Blythe to respond to that.
Well, Professor Murphy, we might come back to that because we have a ATAGI for a bit longer. Sorry, Senator Lambie, because I now have another senator waiting to ask Professor Kelly some questions. So could you just keep yours to General Fruin or Professor Kelly? And then I'll give you the call for a ATAGI later.
Right.
Do you have more, Senator Lambie?
No, that's fine.
I'm sorry to interrupt your flow. I'm just conscious of the time.
That's fine. Pass it on. I can do my questions once those two gentlemen leave.
I'll hand
Thank
you the call as soon as I can. Senator Rennick, you have the call.
Yeah, hi, Senator Gallagher. My question is for Professor Kelly, if that's okay.
Yep. Go.
Professor Kelly, given that there is such a low risk of children getting severely ill from COVID and dying from COVID, how can you justify the rollout for 5 to 11-year-olds, given that the trial data consisted of two groups of around 1,500 each? The second group, the FDA in this report hadn't yet finished reviewing, so I haven't been able to read its data. But given that 1,500 is such a small sample size, and that the actual trial only went for a short period of time, a couple of months, and then they only followed up for about 2.5 weeks after the second dose, don't you think we should wait before we even consider rolling out the children, given that we need to see more evidence?
Thank you for the question, Senator. So as I mentioned, and I may not have been quite as clear as I would, so just to make sure I've got the record correct, I did mention a number of 22,222 children in that age group who have contracted COVID. That's this year from 1st of January to 21st of November 2021. You're quite right that of those, only a very small number, 1.4% in fact, have been hospitalised, and less than 0.05% have been in ICU, and we've had, unfortunately, a death in someone who had other many other illnesses. So the severity is there's no doubt, and we've never said anything differently, that the severity is less in younger people compared with older people. But we've found over recent times, particularly in Victoria, and any parents on the call would know how disruptive it is when there are children, when children in a classroom, for example, are infected. And this is not a trivial infection for many of those people. So it can affect school. It's already been very much disrupted for the last 2 years, particularly in those in the 3 jurisdictions that have had and continue to have outbreaks. We know that in many areas, and this is very well documented globally as well as here in Australia, that children do transmit the virus. So that's something that's come with later variants. Certainly Delta is like that, I suspect, and we already have evidence in Australia that Omicron will be like this as well, that children can transmit the virus effectively and efficiently. And just to take the example of the recent Omicron cases that started with a single person who was infected in a climbing gym in southwest Sydney. Within a week, it has got into 2 schools. Both of those schools are closed in Sydney. It's got into a school, Lynham School here in the ACT. There has been casual contact through the ACT to Gundaroo. So children are transmitters of this virus. The vaccine does, and we know can affect that transmission. It's not only about the protection from severe illness. In terms of the small sample size, you're quite correct. That was something we wanted to see more information than what was originally presented from the clinical trials in the US. That's one reason why we've been cautious and watching what's happening in the US. And I mentioned earlier, you may not have been on the call at that point, but myself and others from the department, the TGA and ATAGI met with colleagues from the US today to hear about their experience of over 5 million doses in that exact age group. So recognising we have about 2.3 million in that age group in Australia, that's a substantial sample size, who they've been following very closely and carefully for vaccine side effects and have not really found anything at all severe. And even those myocarditis cases that we are wanting to know about, there was only 4 in that over 5 million doses. So an extremely rare event. All of those were mild, short-lived and self-cured.
Okay, so in regards to the transmission, though, you have to admit that the vaccines haven't stopped transmission. We know that the Omicron variant came to Australia through vaccinated arrivals. So, and, you know, plenty of people, it's well known now that vaccinated people transmit the virus as well. And so I don't necessarily buy into that. And the other argument that children can't go to school, well, that's, you're trying to put a pharmaceutical solution to a political problem. So I'm not really sure that's correct as well. But anyway, that's your opinion. I just want to touch on the severe pain/injury in the trial was 0.3% for the 1500 trial, first trial I think it was. And I think it was the same for the second trial off the top of my head. That's about a 1 in 300 event. I noticed Professor Skerritt said yesterday there was a 1 in 3,000 chance of a child getting some sort of as he described it, funny. I'm not quite sure what funny means in his terms, but condition from COVID. Given that you could have a serious injury or pain, there's a 1 in 300 chance of that versus a 1 in 3,000 chance, not taking into account infection rate. Don't you think that the cost-benefit analysis doesn't stack up?
So, Senator, just firstly on the transmission reduction, that's not my opinion, that's the science. Yeah. There's definitely a decrease in transmission from the virus, but I'll respect your difference of opinion on that, but it's not my opinion, that's what the studies have shown.
I'll accept that.
Senator Rennick, excuse, the way we run these hearings is that, we allow the witnesses to answer the questions that have been put and then you can respond again. We don't interject. It's just impossible to run the hearing any other way. Sorry, Professor Kelly, continue.
Thank you, Senator. So I couldn't quite hear what you were talking about in terms of adverse events. I think in relation to the or so-called side effects in relation to the vaccine. I think Professor Skerritt is on the line and he may be able to elucidate, but again, from the discussion I mentioned from the US experience, 5 million doses, post-market surveillance, exactly what we've been doing right throughout the vaccine rollout and will continue to do, very close and very detailed information coming in and being analysed on a daily basis. They are seeing adverse events, but it's mostly exactly what you would expect from, and what we've found from the adult vaccination rollout. Pain in the arm, sometimes some fatigue, body pains, occasionally mild fever. They were the key things that came through from the discussion today. And that's very similar to what we've seen elsewhere. There was just those 4 cases, I said, of that side effect that we know about, and we've seen in young adults and older teenagers, and we were very interested to hear about what they were finding in that group. But again, I would defer to the experts who are on this committee today, Chris Blythe in particular, in relation to that.
Senator Rennick, do you have further questions for Professor Kelly or General Fruin?
Look, I have a general one regarding the adult trial, and I've been reading through those papers, and in the initial Pfizer trials, basically they say they didn't test for pregnancy, breastfeeding, frail patients with comorbidities, patients with autoimmune or inflammatory disorders, interaction with other vaccines and long-term safety data. Given that there's only 22,000 in the initial cohort and then 22,000 placebo, and then they ended up vaccinating the placebo group as well, I wonder if you think that really was a big enough sample size, given that Professor Skerritt earlier said this year there was a 1 in a million chance of having an adverse event. I don't know how he could have, serious adverse event, how he could have come up with that number, given that the sample size is only about 44,000 people.
Okay. We might go to Professor Skerritt later. It is a little bit difficult to hear you, Senator Rennick. I don't know whether it's I'm struggling to follow the logic of the content of what you're saying or the volume of what you're saying, but what was the paper you referred to initially? You said you've been reading the papers. It might help witnesses if you're able to articulate what paper that is that they are being asked to respond to.
Yeah, so it was the initial Pfizer report that reported back on, the initial safety data from the trial, and then it's known. I'll read it out to you. Let me just
who the author is. Senator Rennick, the author of that report. You said the initial Pfizer report. It's not clear to me what that is.
Yeah, so it's the EU RMP version .1.0 dated 21st December 2020.
Okay, thank you.
Senator, I think that those questions probably are best addressed to ATAGI. I think Senator Rennick's talking about the early trials, which have certainly been superseded by the hundreds of millions of doses of real-world experience and safety data we have now. For example, in the AstraZeneca trial, the TTS condition wasn't picked up at all. And I think Senator Rennick is right that some of those early trials were relatively small numbers, but we in Australia have been in a position of not starting our program until the rest of the world had delivered tens and hundreds of millions of doses, and that is a much more realistic readout on the safety of these vaccines. As Professor Kelly said, in the US, 5 million children with 4 cases of pericarditis. That is a much better real-world safety readout than any of those initial trials. But the ATAGI co-chairs have considered all of these issues and would be happy to address the issues of pregnancy, immunocompromised people. But we now have such good real-world safety data, we're much more confident than we might have been just reading those initial trials. So we could put them to ATAGI's chair if Senator Rennick would like.
Yeah, thank you, Professor Murphy.
Thank you.
Senator Rennick, we might do that. We're just going to break in a minute for 15 minutes and then we'll come back and we'll have the TGA, ATAGI and representatives of the Department of Health remaining here until 3 o'clock. So it might be, if you're able to stay on the call or rejoin, that might be better. I'm conscious of time, so I'll just do a quick check that with Senator Davey and Senator Lambie. Do you have anything further for Professor Murphy or, Professor Kelly or General Fruin? Okay.
All good for me.
Thank you. Professor Kelly, just before I let you go, is there any evidence or what is the evidence about Omicron and vaccinated Australians or vaccinated people? Are you still waiting for information on that? But I think you said in one of your statements that there is reinfection happening. Are you worried about that? Does that present any particular challenges?
So we are somewhat hampered so far, Senator Gallagher, about on the numbers that we have very good data on. So as I mentioned, there's over 1,000 cases. That's last week there was very much fewer than that that have been reported so far as confirmed cases around the world. What we're hearing, most of it is anecdotal up to now, is that quite a few of those people that have travelled from South Africa to other countries, or Southern Africa, I should say, but particularly South Africa, had had previous illness. In fact, at that meeting we had with the South African authorities last week showed that they've had a very high rate on serological diagnosis, so a blood test showing that they've had previous infection right throughout, particularly the adult population. So they've got a very high previous infection rate, they've got a very low vaccination rate. Of the travellers that have gone overseas and been diagnosed with Omicron when they've arrived in, for example, the UK, quite a few of those have been previously infected and doubly vaccinated. But they've all had extremely mild disease or no disease at all, just asymptomatic. That's very similar to what we've found so far in Australia, very small number of less than 40 cases. Quite a few of those initial 10, all but one of those was fully vaccinated, some as recently as a month before, and with Pfizer.
So do you know on the 37 that you have now, do you know how many of those are fully vaccinated?
I don't have complete data on that, Senator, because some of them were only notified today, and quite a few of them are relatively young children too, so they haven't been vaccinated. So it's a mix. Some are partially, some fully, some not at all. But again, no one has had severe illness. No one has gone to hospital. Only one child, a 7-year-old, that was reported from New South Wales, has been to hospital overnight for observations. But other than that, no treatment has been required. So the challenge in South Africa, it's a very different country to here. They have a much younger demographic. I think only 5% of the population are over the age of 65, for example. High rates of HIV and other illnesses. And so hospitalisations, cases have rapidly increased over the last few weeks. Hospitalisations in some, but not all provinces have increased slightly, but not to the same extent as the cases. And from one particular specific report we've received from a children's hospital in Gauteng, which is one of the more populated areas of South Africa, they actually test every child that comes to hospital for COVID. So they've found an increase in COVID cases, but that's because they're being tested. They're not at all severe, and in fact they're there with COVID rather than from COVID, if that makes sense.
Okay, so it's really going to be a matter of time to work out how this will play out across Australia, really, in terms of Delta versus Omicron and how that spreads. Is that your view? We need more time to see how that rolls out, for want of a better word.
Yes, so I think we do. We definitely need more time, and the work we've been doing with the rest of the world will help that. Australia has an unusual, very positive two areas which is different from most of the rest of the world. One is very few of us have actually been infected with COVID-19 throughout the whole pandemic on a global comparison, and we have one, as has been already mentioned, one of the highest vaccination rates in the world. So. There's no doubt it's transmissible. My sense is that the vaccine will work, but whether there is a slight decrease in the effectiveness, that remains to be seen. And the severity, I haven't seen any evidence so far that it is more severe, but Of course, if it is transmissible, there will be some people that will get severe disease, there's no question. And we have no evidence yet in the world of how this might affect older people, for example. So that's something we're still gaining that experience.
Okay. Look, thank you very much for your time. The committee will now suspend for a short break. Thank you for your attendance today, Professor Kelly and General Fruin. I'm not sure you took anything on notice, so you don't have to worry about that. But if you did, can you answer it on time? And the committee will recommence its hearing at 1:25. Thank you. Its hearing, and I understand have we lost General Fruin and Professor Murphy? I got another message that they would be around.
Professor Murphy's here. General Fruin and Professor Kelly have gone off to their respective offices, but if the committee requires them, we can recall them. They're doing other meetings.
I see. Thank you.
They always prioritise the Senate.
Do you? I think that's an open question before this committee, Professor Murphy, but we do thank and appreciate very much the attendance that you've made and your officers this year in particular. So I'll just check if I still got Senator Rennick on the call.
Yes, Senator Gallagher on here.
No worries. All right, so colleagues, we now are opening it up to ATAGI and the TGA and Professor Murphy, who is here representing the Department of Health. So perhaps if I can go now to ATAGI and just ask, is that you, Professor Blythe?
Professor Blythe would be best to respond to the paediatric questions, being a paediatrician of some note.
Yes. Wish I had one of those handy a few months ago, but can I ask you whether what the sort of plan is for the process now for the final approvals of the Pfizer vaccine for the 5 to 11-year-old age group? You may be on mute, Professor Blythe. Or we may be having more concerning
Can you hear me now?
technical. Yes. No, we can.
Sorry, is that better?
Yes, got you.
Okay, sorry, Chris Blythe, co-chair of ATAGI. Thank you for the question, Senator Gallagher. So given that the TGA has provided their approval, ATAGI will be finalising its advice this week and delivering that to government at this stage. Clearly that was contingent on the TGA approval, which has now been given, and so we're in the final stages of that and we'll be delivering very shortly.
And does ATAGI go over the TGA approval in any way? Like, do you go through a process where you kind of review the TGA approval, or is it more now the mechanics of how and when and what, the arrangements are put in place? Because I just note there is some concern around the safety of the vaccine. So do you have a role in safety, I think is the short question.
I think we do have a role in safety, but the two processes are independent. But importantly, we're looking at very similar data sets and the data. We do have an opinion on safety because that will, of course, inform how you would roll out a program. Yes, I can answer the responses about questions about safety because that is very much been incorporated in our deliberations. This is the age group where the risk of hospitalisation is the lowest of any age group, so that balance between benefit and risk needs careful consideration.
And so can you just talk through the committee how you do that? So you get the work that the TGA has done. I understand that it's more integrated than that you would be talking to the TGA as they're going through their processes, even though they're independent. But when it lands at ATAGI's desk, what happens then?
Well, because they are independent, we have been working up our advice for a number of weeks, thinking about all possible scenarios based on what the TGA may be doing with their review. So some of the factors that we absolutely need to consider in this piece of advice is, one, what are the direct benefits to the child? Are there any indirect benefits that we need to understand? And by that, I'm thinking about things such as being able to get children back to school, keep children at school, prevent transmission. Are there any safety concerns, mild safety concerns, and more importantly, rare safety concerns that we need to factor in? And importantly, then some of them, just the practical steps. You know, given this comes in a different vial, when there's accessibility to the vial, what sort of training materials are required to help healthcare providers make sure they can deliver a vaccine like this safely and effectively? So all of those factors actually have been incorporated in our deliberations for a number of weeks pending this advice. And importantly, now that the TGA recommends, we can, well, now that the TGA has approved, we can then provide our advice.
Yeah, okay. So it's probably saying that you're going to be looking at that now and making a decision by the end of the week. You then provide that advice to government, and then that presumably feeds into General Fruin's, how he implements whatever decision you come to. So it's probably an unfair question to ask you at this point. So dodge it if you want to, or answer it with your other professional role. But do you have any safety concerns around vaccinating the 5 to 11 year population in Australia?
We have looked at the safety data in this age group very carefully because, as I said, that risk-benefit is different in this age group compared to older people. So one, both the clinical trial data, which is reassuring, but I do acknowledge the numbers included in the clinical trial are low. And so that's why we've gone to countries who are using this vaccine in large numbers, such as the meeting that Professor Kelly referred to this morning. That has been very reassuring to me and very reassuring to a number of the committee members at this stage, and will clearly inform our advice. Do I have any significant safety concerns? No, I do not have any significant safety concerns, but with any new program, we'll be watching this incredibly closely as we roll out, both locally, but importantly, as we continue to roll out internationally.
Thank you very much, Professor Blythe. Is Professor Skerritt there? I can't see.
He's joining at 1:45, Senator. I think he's been officiating at a graduation
Okay,
ceremony,
no problem.
so
I'll come back to him.
He'll join as soon as he can get to the computer.
No problem. I'll go back to Professor Blythe then. Professor Blythe, on booster vaccines, have you got a timetable in terms of your decision making there? We understand that the issue of bring forward of the 6-month mark was referred to ATAGI by government, and could you just outline where you're up to with that?
Sure. So even prior to the emergence of the Omicron variant, ATAGI had set a line to say, actually, we'll be reviewing the booster program, particularly as we move into the large numbers that General Fruin talked about. Really, from January, February and March, we're getting to large proportions of the Australian population. And so we had already committed that we'll be reviewing that program. Okay. Reviewing that program both with the gap, as in the 6-month gap, which we stand by at the moment, whether we should be offering a 4th dose to those immunocompromised individuals who are already recommended an early 3rd dose. The role in adolescents, we're not recommending 12 to 15-year-old boosters at the moment. So all of those things are on our work schedule. Clearly, with the Omicron variant, Professor Kelly tasked us with to look at the data about whether we believed we needed to make an early decision, and there was robust discussion about that. But given the absence of data about how well our current vaccines are working against this variant, we thought it was premature to adjust our settings at this stage. But of course, if evidence emerges, particularly from some of the in vitro or some of the population data that is necessary, we'll have to review that and be very happy to.
Okay, so there's a bit to unpack there. So that you are you saying to me at the moment you're not changing the 6-month decision, or you're currently considering that, but you were considering it before Omicron came. So you'd sort of self-referred that in a sense.
Absolutely. So that has
Right.
always been an intention to review that time point. That time point was based on some of the data about when immunity is starting to wane. In the setting of Omicron, I know a number of commentators have asked whether we should be going early at this stage. We will need to review that as well at this
Okay.
stage. That is absolutely on our work plan.
Okay. And do you have a time frame for making that decision, considering that, we are sort of at the beginning of a big, third round of vaccination rollout over the next 6 months?
We do not believe, based on what we're seeing in the Omicron data at this stage, that we need to make that decision or change that setting at this stage.
Okay.
Now, clearly, we will be needing to review this data more fully as it comes to light. It's changing day by day at this stage. And that really aligns with our preset review point, which was really early in 2022.
Okay. And then you mentioned that you're also considering whether a fourth dose is required. Is that only for immunocompromised Australians at this
I
point?
need to be really, really clear there. What I'm talking about is there is a small group of immunocompromised individuals who have already been recommended to have a 3-dose primary schedule.
Right.
We have been silent on whether they would need a booster at this stage and are actively reviewing that data at this stage. So this is those who have severely immunocompromising conditions such as solid organ transplant, kidney transplant recipients, or those on heavy immunosuppression are already recommended to get a 3rd dose 2 months after their second to make sure that their immunity is as good as we can get it from their primary schedule. We've remained silent on whether they warrant a booster at this stage. That is something that we need to review and provide clarity to providers and the community about.
Okay, all right. So that would be a much smaller subset of the Australian population. Okay, and
That's a very small subset,
Yeah.
and importantly, we have
Yeah.
not had a review nor believe there's benefit of 4th dose boosters until we've actually got anywhere near our 3rd dose, if you know what I mean, our routine 3rd dose boosters, which we're rolling out at the moment.
yeah, okay. In terms of, I've lost my train of thought now, where I was going with that. I might go to Professor Davey and, Senator Davey, sorry. And
I wish I was a professor. I'm not quite.
I was trying to process everything Professor Blythe just told me and I've lost my train of thought. Senator Davey, you have the call.
Thank you very much. Professor Murphy might be the one to answer this, but do we have any modelling on the impact of vaccinating 5 to 11-year-olds? So we know we did the dose. What was a comfortable vaccination rate for the general population of 16 and over of 80%. Have we actually modelled what the impact, say whether we get 10% of 5 to 11-year-olds vaccinated, 50% or 80%, and the efficacy of the program in stopping the spread of COVID?
So, Senator, I don't believe there's been broad population modelling. There's certainly been some in the Indigenous population that showed that it would be quite important. Dr. Dutoka could talk to that. But I'd have to take on notice whether the Doherty have done specific 5 to 11 modelling. I don't know whether Dr. Bennett's online and she might know, but I'd have to take that on notice, I think. But if Dr. Dutoka can talk about the Indigenous modelling.
Thank you, Thank you, Senator David. In the First Nations context, noting that the 5 to 11 cohort is a much higher proportion of the overall population. So in general population, 5 to 11-year-olds are about 9% of the population, whereas in First Nations communities are about 15% of the overall population. So there's a lower whole of population coverage if you just go 12 pluses than there is in other Australians. And as such, the specific modelling that the Doherty and broader researchers team undertook to underpin the National Cabinet's reopening plan for First Nations communities, which was done in partnership with the National Aboriginal and Torres Strait Islander Advisory Group on COVID-19, looked at the differential impact of vaccination for 16 pluses, 12 pluses and 5 pluses in First Nations communities. It did show, particularly in remote communities where some of the intrinsic social determinants of health conditions, including the number of people living in the same household, increase the transmission potential of the virus if it takes hold in the community. The vaccination of the 5 to 11 year old population will make a significant difference in bringing down the reproductive number for the virus under 1, thus helping control outbreaks, potentially without more significant public health and social measures like what we are currently seeing in some of the excellent responses to the Northern Territory outbreak and others. So very significant impact in First Nations communities.
And was any work done to sort of determine whether there was a huge differential if you only got 20% of the 5 to 11s vaccinated compared to 80%? Because I'm just interested, and I've heard anecdotally a lot of adults who have been vaccinated are not necessarily going to vaccinate their children at the same rate. So we may, as a population, when we've got over 90% of the 16 plus year olds vaccinated, we might only get 40% of the 5 to 11 year olds vaccinated. And I'm wondering what sort of an impact that would make.
So, Senator, I don't think that modelling for the general population has been done, but I think that is in the forward plan of the Doherty team to do that work.
And Ms. Balbana may be able to comment on some of the sentiment analysis that I think it's a little bit more optimistic in terms of intention to vaccinate children should a vaccine be approved. I don't know if Ms. Balbana is online.
Ms. Balbana, would you like to comment on the intention to vaccinate for 5 to 11 year olds?
Yes, I'm online. I've managed to start the video. So yes, we are monitoring intention to vaccinate younger children amongst parents to understand what that's likely to be. And it has increased over time, along with intention for adults to vaccinate, but it is still lower than intention for older children and intention for adults. So you're quite right, Senator, that we may not see the same overall vaccination rate for younger children as we're seeing for 12 to 15 year olds or for adults. But we still expect that there are, a majority of parents who are intending to vaccinate their children in that age group.
Excuse me. And someone in the last session mentioned that, it was General Fruin with the rollout of 5 to 11 year olds. They're preparing for early January, but they mentioned the states may decide to do an in-school program. Has there been any conversations department to department about that, what that might look like?
So, Senator, I think there are ongoing discussions with some of the states and territories about the potential for that. It probably wouldn't be, given the timing, it probably wouldn't be first doses in the main because that's before they go back to school. But ATAGI have not reached a final decision on the dose interval for children, but it may well be longer than the 3-week first dose that adults had for Pfizer. And so children are likely to be back at school in time for the second dose, and some states are actively considering whether they'll do some school-based programs, but I don't believe any firm decision's been made on that. Ms. Blewett is here representing the General. She might be able to comment further.
Thanks, Senator, and thanks, Dr. Murphy. Tina Blewett, Deputy Coordinator General of the National COVID Vaccine Task Force. Nothing really further to add. We are just consulting with states and territories and asking whether they propose to run school-based programs. And the key point is, as Dr. Murphy said, it's around if we're aiming to commence the program indicatively from the 10th of January, we'll be aiming to get first doses in schools, as you know, don't start until either the end of January, some of them are a bit later in February. But we're definitely, and if my recollection serves me right, Victoria indicated on the weekend that they are exploring a school-based program.
do you think school-based programs help the uptake within that age group? Because I know with other vaccinations that are run through schools, often it's the fact that all their classmates are going in to get their shots at the same time. Has there been work done to actually assess whether that has more of an impact on the uptake of vaccinations going via a school-based program?
It's multifactorial, Senator. I think many of our school-based programs are actually in older children, in teenagers, where we run the HPV programs and other programs. Younger children, I think most of them get their immunisations through their local GP or their now they're pharmacists. They'll be able to. Younger children haven't had access to pharmacist vaccination before, but it's the parental decision, and I think the parents will often find having the GP's reassurance about it to be something that they factor into it. But it's a multifactorial thing, and if we do find that some states run a school-based program that can sort of build upon the primary vaccination, which we think will be in primary care.
And just on more general, we've got a very good vaccination uptake rate for childhood vaccinations on the immunisation schedule. Does that give us confidence that we think that there'll be a good uptake of these vaccines?
I think that does, Senator. We have one of the highest childhood immunisation rates in the world, close to 95%. And that was one of the reasons why we were always confident we would have a high general uptake of vaccines in the adult community, and that while we've now got one of the highest vaccination rates in the world, and I think the same, I'm actually quite confident that the childhood rate will increase, and as we get more and more confident with the data, I think we'll get a good uptake. Professor Skerritt has joined the call, Chair.
Yes, Thank you. Thank you.
Secretary.
Thank you, Professor Skerritt. Thank you for joining us today. I'll hand the call to Senator Lambie.
Thank you, Chair. I was just wondering, I don't know if there's been any modelling. What does this mean for the 5 or 10% that are unvaccinated? Where does this leave them?
What it means, Senator Lambie, is that unvaccinated people will almost certainly contract COVID at some stage. I think as we start to live with COVID and it spreads through the community, we will probably all be exposed to this virus. It's inevitable. Those of us who are vaccinated are partially protected against picking up the virus, but not completely. But if we do get the virus, we're likely to be asymptomatic or mildly unwell. Those that are unvaccinated will obviously much more at risk of picking up an infection and obviously have a higher risk of getting serious disease. Now, obviously, for those unvaccinated people who are relatively young, they will likely have a mild disease. And fortunately, the people at highest risk, the over 70s, are very, very highly vaccinated in Australia, getting up in the high 90s. And so, but there are still some older people and people with underlying medical conditions who are unvaccinated, and they have a significant risk of getting severe disease and potentially dying. So we certainly would encourage, but they're a tiny proportion now. Our uptake in the older population who are at high risk is extraordinarily high. But those who are unvaccinated, as I said, will likely contract COVID at some stage, and depending on their risk factors, could get more severe disease.
So do you expect to see further lockdowns then if we're reaching that 80 or 90% target?
No, Senator. The modelling has suggested that the relatively small proportion of people who are unvaccinated and susceptible to severe disease can easily be coped with within our health system, all that planning that's being done on health system capacity. So there will be some, hospitalisations and some small numbers of people in ICU, but there is no intention at this stage to do further lockdowns. The intention is to make sure that every single Australian eligible Australian has an opportunity to be vaccinated, and if those, some people do choose not to be vaccinated, which is their right, then they need to be informed of the risk that they are facing. And that obviously depends on their age and underlying comorbidities. But the National Cabinet's been pretty clear that once we hit these sort of 80% particularly vaccination target, then there is no intention to do further lockdowns. There may well be some, if you had a very big outbreak in a low vaccination part, like perhaps an Indigenous community, there may still need to be, some significant public health measures, but big sort of citywide or statewide lockdowns are not currently envisaged in the national plan.
So earlier this year, we had a lot of modelling done about the number of cases, hospitalisations and deaths if we open up at 80% of the population vaccinated. How well are those predictions holding up? Are they holding up to pretty...
Very, very, very well, Senator. In fact, what we're seeing we saw in New South Wales and we're seeing now in Victoria is we're doing slightly better than the modelling. That modelling is actually on our website now. I'm sure the Chair is very pleased to note that it was published on the 12th of November, the jurisdictional modelling according to potential health system demand versus capacity. And what we're seeing in the real world is slightly better than that modelling.
And Dr. Murphy, have you seen, have you picked up much difference between the different vaccines over the last 12 months? Like, would you say there just seems to be some conflicting evidence out there. Are they pretty much delivering all the same? Is one actually better than the other, or?
We don't think so, Senator. We think, there are some trials that show, a slight advantage over one versus the other, but all of the three vaccines that we have been using are all holding out very well in terms of preventing severe COVID, which is the primary reason for our vaccination, and they all seem to have pretty similar evidence of disease prevention of transmission, and they all are showing some evidence of waning at the 6-month mark. But I think Professor Cheng or Professor Blythe could come in there because they're more expert than I am on vaccines. But I think that the general scientific consensus is that all three vaccines are very, very good and have stood the test of time. But Professor Cheng might want to comment there.
Professor Murphy, what I jump in, Professor Cheng's not on the call. I would agree with your position at the moment that all three vaccines are holding up well at this stage. Now, clearly, we are seeing some waning of immunity, and that is the reason for our booster program at this stage. Now, there is variation in how these vaccines are performing in different trials, but actually, the summary, I would agree with Professor Murphy's summation.
Thank you. And Dr. Murphy, I understand if you throw this question around, but that's fine. I'm just going to direct them to you. If there's someone that you think should be answering them, please do so. I do apologise for my ignorance. How worried should we be about new strains? Could a new strain like Omicron send us back to square one? Are these strains getting they're obviously getting weaker? Do you see this strain getting stronger anywhere?
So I think, Senator, what we know about Omicron, and I think Professor Kelly alluded to some of this earlier, is we're still learning. I think the reason there was so much international anxiety about it, and we saw various countries making border decisions, including Australia, was that it had such a high number of mutations in it, much higher than we've seen in any other variant to date, and particularly in the spike protein, which is the which is the target of our vaccines. And so on the basis of that theoretical modelling would suggest that there may be some reduction in both what we call natural immunity, so that's the antibodies people have who've had the virus before, so there's probably a higher risk of reinfection, and there may be some reduction in the antibody protection from vaccines against this variant, but we simply do not know how much that will be. I think most people are confident that there will still be protection to some extent from the vaccines that we have at the moment, and that protection will particularly be against severe disease. We saw that with the beta variant, where the vaccines in the laboratory showed less of a protection, but there was still protection against severe disease. But we're doing those tests at the moment with Omicron, and we will get more and more data in coming days and weeks about how good the vaccines are against it. But most people are confident that there will be some vaccine protection, but I suspect that most people also feel that the protection won't be quite as strong as it is for Delta. But the most important thing is that they protect against severe disease. The other point that Professor Kelly made this morning was that Omicron, as the mutations that it's had may make it a less severe infection. We again don't know that yet. We haven't seen significant evidence of people getting very sick with Omicron, but we don't really have enough data to say that yet. So the reason there was a lot of anxiety about it is because of it's the number of mutations, and people wanted a bit of time to assess it and get that data. But we will continue to see variants. But to date, all of those variants up until now, we said we don't know with Omicron, have all been shown pretty good protection against severe disease from our current vaccines.
Thank you. And I just have one final question. You may not know the answer to this, but did we ever come up with a conclusion of where the original strain actually come from, or we've just moved past that and getting on with it?
So, Senator, there is no... I think that the epidemiological evidence still suggests that it originated in Hubei province in the city of Wuhan in China. There was lots of speculation about how it came from what was likely to be a bat reservoir into humans. There is no evidence that it was anything other than a natural passage through another animal species into the human. There's been lots of speculation. I'm sure you're aware of that, but there has been no evidence, and the WHO has been in and done some investigations, and they can't conclusively say how it came from an original bat host. It clearly didn't come straight from a bat to a human, but how it came there, we simply don't know at this stage.
Okay. Thank you so much. I have no further questions. Thank you.
All right, you're done, Senator Lambie. Okay. All right, no problem. Senator Rennick.
Thanks, Senator Gallagher. I'd just like to touch on a couple of questions. First of all, Professor Murphy, and then I'll go to Atagi. I noticed that Professor Murphy said almost everyone will certainly get COVID. I'm curious as to the basis of that, because in the UK, 10.5 million people have got COVID out of 66 million, so about a 1 in 6 infection rate over almost 2 years. And in Sweden, 1.2 million people have got COVID out of about a 10.5 million people over almost 2 years as well. And both those countries have much longer winters, larger populations, much denser populations. Why do you think that everyone will get COVID in Australia, given that most other countries have an infection rate of between 1 in 6 and 1 in 10 over, 21 months of data?
Well, thanks for the question, Senator. So over that period of time, there were lots of public health and social measures in place in those countries that varied from time to time. There were lockdowns and masks and various measures, and when I was saying most people will eventually be exposed to COVID, I'm talking over a period of some years, perhaps. Pretty much every every Australian adult has been exposed to influenza. These viruses eventually will circulate and progress around a country, and I suspect that most people around the world will be exposed to COVID as it becomes endemic. So obviously there may be some people who have, from other coronavirus infections, that they might have had some immunity and some protection. We don't know for sure, but I think it's pretty likely that most people will be exposed to it and the great majority will be infected. I don't know whether Professor Blythe is more of an expert than I. He might want to add something to that.
No, I think the timeline is uncertain at this stage, but I do agree, given what we've seen internationally and locally at this stage, that we will all be exposed at one point. Importantly, some of the public health measures that are in place at the moment are likely to adjust the rate at which that occurs.
Yeah, okay, I accept that. I should note, however, that Sweden has stayed open nearly the entire time. They had one brief lockdown, but they stayed open most of the time, and they've got a lower infection rate than the UK, which had a large amount of lockdowns. But I'll leave it at that. And just one other question, Professor Murphy, I just want to pick you up on that December statement, that December data, in your July TGR data and TGA data as well. Those gaps in testing were pretty much the same in regards to there had been no testing on failed patients, autoimmune patients, etc. So I'm happy to send you through the document that says that if you want proof of that. But just jumping over to ATAGI, is there any plan for ATAGI to further expand the temporary exemption guidelines? And in particular, I'm thinking about pregnant women. I noticed that you didn't extend the exemption for pregnant women, and I've been contacted by many pregnant women who want to wait to give birth before they take the vaccine, and some of these women are now going to lose their jobs up here in Queensland because, they want to, not sort of give anything to the baby, possibly give anything through to the baby. Is there any chance that ATAGI will further expand those temporary exemptions?
I think it's important, and thank you for the question, I think it's important to highlight that actually pregnant women are particularly susceptible to COVID, both themselves and also their baby. We know that pregnant women have a much greater risk of hospitalisation, intensive care admission, and also their baby has a much greater risk of being born early. And so that is why actually ATAGI recommends vaccination in COVID, in pregnancy, to protect the woman and the baby. So we don't believe, given that actually there is a demonstrated benefit, that there is a need for an exemption, but there's no intention to adjust that at this stage.
Right, okay. I just also want to highlight, I noticed that the FDA has given Pfizer 55 years to release all their data from the trials, from their initial trials. Are you concerned that Pfizer wants to withhold data from the trials and has redacted a lot of data, trial data, in the initial release of that data? Does that not concern you at all?
It's probably a better question for Professor Skerritt from a TGA.
Yeah.
Yes.
Okay. Sure.
Professor Skerritt, do you want to jump in on that one?
Thank you, Chair. So the FDA has been through all of Pfizer's original clinical trial data patient by patient in detail. What we do is look at the aggregated summaries, but we do, as a group of international regulators, of which Australia is vice chair and of which FDA is part of the executive, we've probably had, I don't know if it's 30 or 40 meetings discussing COVID vaccines, I've lost count, and we had a number of meetings discussing the Pfizer vaccine, both prior to its release on the market and indeed as recently as this morning together with the Centre of Disease Control to talk about some of the safety data. So we're very closely joined up. There is data that is redacted that is of commercial value relating to the manufacturer. There was some early information, I think the Senator might be referring to, from some early data in August 2020. Of course, the approvals of a vaccine were based on analyses of data that came through later, and so we're not concerned.
Okay, well then, I noticed that in this latest release of data, the first 500 pages, Pfizer has conceded that there is a large increase in the type of adverse event reactions to the vaccines. Now, I know we've had this conversation before where you've said that basically there's a limited number of recognised side effects. Given with the latest release of this data, will you expand the number of recognised side effects as a result of the vaccines and therefore allow doctors to, say injuries are related to the vaccine, number one, and then also expand the indemnity scheme, allowing people to claim for other injuries?
So, Senator, our role is merely, as you say, to recognise side effects. And at the risk of sounding trite, we'll recognise a side effect as caused by the vaccine if the evidence, on the advice of an expert panel of specialists in that area, and again in consultation with international regulators, shows that there's a cause and effect relationship. If there's not a cause and effect relationship, then it's not a side effect due to the vaccine.
So what's your onus of proof on that?
It's a rather detailed onus of proof. Firstly, you've got to show that in time it was related to the adverse event. Secondly, you've got to show that there's no other plausible mechanism. Thirdly, identify how it could be medically related. For example, a broken bone had nothing to do with having a vaccination. It would be hard to show that bone spontaneous breakage was, just to use a hypothetical, was plausible. Then we also look at background rates, and remember that many things, including myocarditis, have a very significant, quite high background rate in the community. There's a number of other measures, observed versus expected. We slice it by the population. We look at the background rates, not just in the whole community, but also in the particular age group and gender and even racial cohort to get together with our colleagues overseas. So it's a detailed analysis, but we don't just do it ourselves. So if it's a neurological side effect, we bring in some of Australia's top neurologists. If it's a haematological side effect, as we did for TTS, we bring in some of Australia's top haematologists and so on.
Okay, I'll just be more specific with that onus of proof. Are you going to look, go on the balance of probabilities, like in a civil case, or are you going to go beyond the reasonable doubt, and these people have to prove beyond reasonable doubt versus balance of probabilities?
So the scheme which you're talking about, and our role is the medical assessment of information provided by relevant specialists and the treating doctor, is on the balance of probability there's no other likely cause for that effect. It is different from the broader TGA adverse event scheme. So it is a balance. It is a balance of probabilities scheme, and that information will, if it isn't already, shortly be made available in detail so that the detailed claims can be prepared.
Okay, and I note that the Sydney Morning Herald about a month ago said that there were already 10,000 claims for that indemnity scheme. How on earth, if you're going to have to do a detailed assessment of every one, how quickly do you think that you will get through all those, claims? And, my understanding is more and more people are claiming all the time. So it could end up, there's been up to 80,000 reported cases for the TGA, of which I imagine.
Okay.
Senator,
can I just jump in there? Can I just jump in and say, if someone's not on mute, could they mute? There's a lot of background noise. Professor Skerritt, you don't have the best line, so there is.
Sorry,
I don't know what's going on there, but it is quite difficult to follow some of what's going on. Professor Murphy, did you have something you wanted to say?
So Ms Shakespeare is the relevant official who can talk about the indemnity claims, and I think she might be best placed to respond to this issue about the intention to lodge and the claim scheme.
Okay, I'll hand to Ms Shakespeare if she's online. I can't see her.
I'm here.
Okay, you are here. We can't see you, but we can hear you.
Peggy Shakespeare, Deputy Secretary, Health Resourcing. I'm not sure why my camera's not working.
No, we can see you now, Ms Shakespeare.
Great. So we haven't actually received claims through the Services Australia portal for the vaccination claims scheme because it hasn't opened. It will open officially next week. We've been contacting directly some of the families of people who were deceased and are talking them through a fast-tracked application process. So I think that the number that you referred to, Senator Rennick, were the people that had registered their interest in the scheme. We're contacting them all at the moment by email to provide them with more information about how they can make claims, about information for the types of injuries that will be covered by the scheme and the sorts of documentation they would need to get together to put in a claim. So I don't think it's the case that we'll have that many claims actually submitted. Those were registrations for people who are interested in the scheme, and we know that we at least had a couple of thousand of duplicate registrations there. So those numbers are probably a bit overstated.
Right, okay. I just want to come back to ATAGI and the exemption for pregnant women and tie that back into the trial data from Pfizer where they said that they hadn't tested on pregnant women. Now, I know there's been one subsequent test on pregnant women that went for about 2 months and tested mainly women in the third trimester. However, that trial didn't then go on and continue to monitor the baby's health after the baby was born. Why isn't ATAGI taking into account the lack of detailed trial data on pregnant women, in assessing the risks and rewards of the vaccine?
Thank you for the question. I think ATAGI has taken into account the lack of trial data, and that is why ATAGI, in the early rollout, particularly with low COVID numbers in Australia, did not strongly recommend pregnant women get vaccinated in the first part of the rollout. However, once we had emerging data from large studies from Northern Hemisphere demonstrating, one, the safety, but also the risk to pregnant women and babies of getting COVID, we adjusted our recommendation at that stage. There remains limited trial data, but importantly, there's a wealth of real-world data demonstrating not only of benefit to pregnant women and babies, but also the safety of that approach, and that's why we strongly recommend. Some of these data particularly highlight that actually the rate of adverse events in pregnant women of vaccinees versus non-vaccinees are not significantly different. And so based on these data and the potential benefit is why we would strongly recommend pregnant women be vaccinated during pregnancy to protect themselves and their baby.
Okay, well, can you send me those trial studies through, please? Can you take that on notice? Because I'm only aware of one trial and it was quite short and had limited numbers. So I'd be curious, I'm keen to see what data it is that you're relying on. Anyway, look, I'll leave it at that.
Professor Blythe, sorry, Senator Rennick, Professor Blythe, is that something you're able to do to provide to the committee?
Sure.
If it's not
Would come via the department, Senator.
Of course,
so the question should be addressed to us. Yeah.
Well,
sure.
I presumed that's where it would go. So, okay, if it's not too onerous, that would be useful. Maybe we could convince.
It's not, Senator.
Maybe we could convince Senator Rennick that the vaccination program is safe. Maybe.
Well,
Professor Skerritt.
Talk to people that talk to me, but anyway, go on.
Yeah. Professor Skerritt.
So I was just saying we already have assembled that information. There's about 5 studies now on pregnancy showing no difference in pregnancy outcomes. Sadly, as we know, quite a significant number of pregnancies, even in apparently healthy mothers, do end in miscarriage, and it's extremely sad for families of those involved. But the key thing is those studies have shown there is not a difference between the vaccinated group and indeed the unvaccinated group in terms of pregnancy outcomes. But through the department, as Secretary Murphy said, we're happy to share those studies.
Thank you.
Thank you.
Senator Rennick, do you have further questions?
Look, I mean, I'm sort of repeating myself, but I'll ask ATAGI this question from a question I asked earlier on. Are you satisfied that there's been enough trial data with the children, given that there's very low risk of children getting ill from COVID and subsequently dying? Are you satisfied that the trial data is big enough, given that 1,500 is quite a small sample size when it's going to be rolled out to millions?
Thank you for your question, Senator Rennick. As I said previously, 1,500 is a relatively small number, but actually that's to demonstrate that the vaccine works and gives a description of the safety profile. To picking up on your question about before, I'd refer you to the study protocol, which outlines what the definitions of severe side effects are. I think that would be very useful for you also. But importantly, that is why we've actually gone to international bodies that have been collecting these data. As more than nearly 5 million US children have been vaccinated, we have been looking very closely to this data to find out what they're really seeing, to give us greater confidence compared to the trial data. Importantly, both of those factors have influenced our decision and will influence our advice that's forthcoming.
So do you think that's ethical to be treating children as experiments if you're effectively saying, well, we're going to just roll it out and then use the children as an experiment rather than actually conduct longer trials, which normally take up to 7 to 10 years for drugs? This trial went for two months, the Pfizer trial, and only looked at adverse events for up to 17 days median duration. Is that really satisfactory?
As a paediatrician, I don't think I agree with your position there that we're experimenting on children.
No.
What we do when we assess a vaccine is we look at the benefits and the risks. Now, I appreciate that this age group, actually, the risks of severe COVID are clearly lower than other populations, and so that's why we've actually taken a cautious approach, taken our time to assess that. But actually, that is not an experiment. That is basically using data to inform rollout of a program. We do not have the capacity to wait for 7 years waiting for data to emerge in the setting of a pandemic. If there's an active problem at the moment, we need to use the best data we have at this stage from clinical trials, from real-world evidence to inform our policy settings.
Thank you.
Senator, could I-
Thank you, Professor Blythe. I will go to, sorry, Senator Rennick, I will go to Professor Skerritt, I think, in light of the allegations that you've just made in the committee, and I would like to say that the committee does not believe that there are experiments being conducted on children. Professor Skerritt.
Thank you, Chair, for your indulgence. I just wanted to correct one thing and comment on another.
Just
Clinical
one thing.
trial.
Just one thing.
Yes. Well, the phase 3 part of a clinical trial of a medicine or a vaccine does not take 7 to 10 years. It is a group of people assembled for a period of a couple of months where they look to see whether the vaccine is causing an antibody response and whether it is preventing against infection. And so the actual duration of this trial is not all that different from the normal duration of the trials. Clinical trials do not take 7 to 10 years. With respect, I think the Senator is confusing it with the normal chemical drug development pathway from the very first time a chemist synthesised a molecule through to the drug being available in man. So it's important to emphasise that clinical trials do not take 7 to 10 years, Chair.
Thank you very much, Professor Skerritt. I think that is very important. Senator Rennick, can you just hang on a second? I think that is an important clarification. Senator Rennick, do you have further questions?
So you're saying that it's typical for a trial to last 2.5 months, number one, and for a trial with the Pfizer one, it's mRNA technology. It's new technology. It's never been rolled out as a vaccine before. Are you saying that 2.5 months isn't the standard time frame because, or is the standard time frame? Because I've followed drug production in another life quite a lot, and these things take years. I mean, I've had had a stock that's still going on 5 years later with its drug trials, and that's for a cancer stock. A cancer drug where the risk of cancer is much higher. And finally, I don't think we've got a pandemic of COVID amongst the children. I think that's alarmist language to use the word pandemic, given the low death rate and fatality rate and hospitalisation rate amongst the children.
Okay. There's a lot there, Professor Skerritt, to unpack. If you could work through those, I think it is important.
Okay.
Thank you.
Okay, we'll work through them then, Chair. Firstly, we've had 22,000 cases of COVID in the 5 to 11 in Australia, and by any measure, that's a significant number of cases. As I've said before, we shouldn't just use deaths as a measure. The limitations on those children being able to go to school, the fact that especially in unvaccinated families, there's infection of parents and grandparents, the effects on mental well-being of children who have been infected and therefore have had to stay home and be isolated. And of course, the 1 in 3,000, 1 in 3,200 chance, which when there are 22,000 kids, that actually is quite a few kids who develop this multi-system inflammatory syndrome, which the US Centres for Disease Control has shown to be quite serious and lasting for many months. It's different from long COVID. So I reject the assertion that COVID is nothing much for kids and it doesn't matter if they catch it. Going back to clinical trials, how the children were done is the same way the children's flu vaccine and other children's vaccines that have started life as adult vaccines and then modified for children's were done. It's what's known as an expansion population. So the detailed clinical trials going through all the phases were done in adults, and then they're done in adolescents, teenagers, and then finally as an expansion population in children. And the main measure was to show that their immune responses were the same as the adults and the adolescents, and that there weren't serious safety issues from those populations. And that is why that trial could be done in 2.5 months. Now, again, as Professor Blight said, we're monitoring the rollout in those children, and the fact that the US is almost a month ahead of Australia and actually will be 6 weeks ahead of Australia does give the opportunity, although I reject the term guinea pigs, to reflect on their experience. And after over 5 million vaccinations in the US, we've heard from CDC and FDA colleagues that the number of serious side effects are extremely low in children.
Professor Skerritt, thank you for that. Professor Rennick, I feel like I've indulged you enough with this line of questioning. Do you have another question?
Yeah, last one, thank you.
Okay.
So have we done any, and anyone can answer this, have we done studies on the impact on children or adults of multiple booster shots every 3 to 6 months?
No, because at the moment there's no one having booster shots of a vaccine every 3 or 6 months. People would be up to their 7th or 8th shot, and that isn't done in every country. When there are booster shots, and there was a major study released in the top flight medical literature just last Friday, looking at booster shots of all the major vaccines on top of, so it was a combination. So it was booster shots times all the different first shots. And there was a very thorough study of adverse events and vaccine efficacy. That was the most thorough study, but there's been about 8 or 9 in the literature on booster shots. But because no one has given 7 or 8 booster shots of this vaccine, those studies have not been done. And we hope that we won't have to have 7 or 8 those booster shots. But if it does turn out we've got to do these studies annually, there will be detailed safety follow-up.
Thank you.
May I, Senator Gallagher?
Yes, sure, Professor Blythe. Yeah.
Importantly, we have looked to the international data about the safety of booster shots, and there's a wealth of data coming from countries that are a number of months ahead of us in that space, looking at the rate of adverse events in myocarditis and are seeing very reassuring data. Importantly, all of those studies are in adults. There is not a program at the moment that's running, a booster program in children at this stage, and clearly Australia has not made the decision about going to a booster program in children without a review of these data.
Okay. Senator Rennick, that's been quite the journey. Have you no further questions from you?
No, I'm fine, thank you.
Did you want to withdraw the allegation that we're conducting experiments on Australia's children?
No.
Right, okay.
No, Australia's or America. I didn't say Australia's children, I said America's children. They're the ones that rolled out after 1,500 in a trial, but anyway, leave it at that.
Okay, well maybe you need to talk to a few parents who've watched their kids struggle to breathe with COVID to understand the value of a vaccination program.
Well, I'm happy to do that.
Yeah. Well, give me a call. Give me a call, Senator Rennick, and I'll let you know what it's like. And I guarantee I would have done anything to get my kid vaccinated rather than get COVID-19. So,
okay, and I'm happy to do that if you're happy to meet people who've suffered vaccine injuries.
It's probably more useful than some of the websites that you're reposting. Anyway, thank you.
Senator Gallagher, it's not becoming of a chair.
Well, I don't think it's becoming of a member of the government to run the lines that you've been running in this hearing, and I think it's deadly serious, and you've got responsibilities which you're not observing, to be honest.
And I do take them very seriously, Chair,
okay.
Which is why I'm asking these questions, and there are a lot of concerned adults out there that don't want their children vaccinated, and I'm merely putting their views forward.
Well, hopefully they will have been reassured by the very extensive evidence that's been given, and perhaps you can send the links to this hearing where we've had the benefit of Australia's experts explaining exactly what is happening and the evidence that underpins those decisions. And maybe they will be reassured by that, by the facts, to get their children vaccinated. Here's hoping. Okay, let's move on. On the issue of disinformation, I feel like it's appropriate to enter this space now. It seems that there are members of Parliament that aren't convinced about the vaccination program and the vaccination program for children. have you been asked to provide any extra information to these members of parliament by the government to reassure them about the safety and the reasons behind the vaccination program? Professor Murphy, perhaps if I start with you and then see if the TGA or ATAGI have been asked to do anything to combat some of that.
Thank you, Senator. I've actually brought Professor Kelly back into the room because he has specifically been tasked by government to brief MPs, and as I did when I was CMO, briefing party rooms and groups of MPs. So, Professor Kelly.
Thank you, Secretary. Thank you, Senator Gallagher. So, yes, I have briefed on multiple occasions both sides of the House, actually, and also to the crossbenchers in relation to COVID-19. I haven't specifically been asked to talk to specific members, but rather in those general fora. I would say there's been a lot of course, countering of misinformation in our communications campaign and in other ways, as well as in as many forums as we can humanly attend to correct these misconceptions, I would say.
Okay, so I'm aware you've been briefing the parties and crossbench. So, but specifically in relation to the members of parliament that are out, not supporting the message or the vaccination rollout, your evidence is that you have not been asked to speak to them individually and provide them with any additional information.
Not specifically, Senator, but again, for those that are in any of those, either the crossbench or the Labor Party or the coalition party rooms, they would have received invitations to come to those settings. And I can't absolutely say whether they were there or not. There were large gatherings, and most recently, of course, online.
Professor Skerritt has provided a lot of information to various members of parliament who might wish to comment.
Thank you, Secretary. I guess in my role as head of a TGA, I've been contacted directly by a number of members and senators, and also contacted through Minister Hunt in particular, but also Minister Colbeck and I think even Minister Coleman, and have had to correspond. And indeed, I've also been asked to be on teleconferences with some members and senators. I haven't done the group briefings that Professor Kelly has, but more on a one-on-one basis. And we've provided data on children and the experience in other countries. We've also emphasised that we will continue to particularly focus on adverse events in children, as we do for all medicines and vaccines. It's obviously the highest priority group, and we will report those open and transparently in our weekly safety reports.
Okay. And how damaging do you think it is for members of parliament to be pushing misinformation or disinformation around this? I mean, does it make your job harder or easier?
Senator, two parts of your question. In one, you've asked me for an opinion, so I'll duck that. But you've also asked me a factual question whether the job of TGA is made harder or easier. Certainly, it consumes a significant amount of time having to do additional correspondence to rebut allegations and also to rebut any assertions, because social media misinformation, unfortunately, has been, I guess, one of the major hallmarks of this pandemic. So to answer your factual question, has it made the job harder? It has, because it's created a large amount of additional work. And of course, our main priority is, of course, safety, efficacy and quality of these products.
Is there anything further we could be doing, do you think, to counter some of this, particularly as you're about to embark on or not you, Professor Skerritt, but as we are about to embark on a rollout of the vaccination program to children? Is there more that can be done? Yeah.
Well, again, our department and the government and many parts of civil society are doing a lot in terms of communication and education. We talked a few minutes ago on pregnancy, and a group that normally is highly critical of government and highly critical of regulators, the Health Issues Centre, actually, to their credit, conducted a very good consumer forum explaining the safety of vaccines for COVID in pregnancy. So I think that there's a lot of good mobilisation of forces going on. Of course, as leaders in our society and community, I think, with respect, I think our members and senators do have a responsibility to be measured in their comments and think about the implications of what they say.
Yeah. Okay.
Senator, Ms Balmano might be able to comment on the 5 to 11 communications campaign that is
Yes, I was
will
going
be
to,
rolled out.
yeah, I was going to go back to Ms Balmano. I think she spoke earlier, and to begin with, my question was, what does your research show about parents' views about vaccinating children? I think you said it was lower for children than it was for other groups, but it was increasing. So could you perhaps explain that a bit more?
Yes, so intention is increasing, and that we also saw that with adults earlier in the vaccination rollout. In the early days, people are looking for more information. They're looking to understand what the potential risks are, etc., and those things impact on their intention to vaccinate. We're in a similar situation now with children, where it is obviously going to be very important that the information is out there, that it's clear what the risks are, what to look out for, but also to put those into perspective for parents in making those decisions. So that's going to be a critical part as ATAGI obviously finishing their advice. We'll take the work from both the TGA and ATAGI and use that in multiple ways to make that available to the community so that people can make those informed decisions. And we would expect that both that driving out of that information and the gradual normalising of vaccinating and people knowing other people who have vaccinated their children will continue to drive the vaccination rates up.
Okay, but my question was, where are they now? Like, what is it, and what is it compared to, at the comparative stage with the adult vaccination rollout?
I'd have to take that on notice to get the exact comparative stage, like just before we implemented, because intentions to vaccinate have changed quite a lot over the course of the last 12 months.
Okay.
For adults as well.
I could ask, and I will ask again. I know I'm probably not going to get them, but if you could provide those surveys to the committee, we would greatly appreciate it.
So we do publish the outcomes of our research on a monthly basis now. We're happy to send that through.
Is that the one about, does that cover children?
One yet?
Okay.
The more recent ones will, but previously it hasn't, no.
Okay. And so you're doing that every month, are you, as they become available?
Yes, so we've been publishing sort of a summary because, as I've talked about before, there are multiple different sources of information, some public, some not public.
Okay.
We tend to summarise and do a monthly summary and publish that. The introduction of looking at intentions in relation to children is obviously more recent, so that'll start to appear from
Okay.
Yeah.
All right. Thank you. Can I, sorry to jump around a bit, but I'm trying to finish before 3. Can someone explain what is going to, once the booster program is rolled out, what is going to constitute fully vaccinated? Are 2 shots where you get your current green tick, is that fully vaccinated and then you get a booster, or is it going to move into having a requirement for 3 shots to be classified as fully vaccinated?
So, Senator, at the moment, ATAGI and Professor Blythe can comment, have felt that there's not sufficient evidence to say that someone who's had 2 doses needs a 3rd dose to maintain their fully vaccinated status. So at the moment, we are regarding anyone who has had 2 doses as fully vaccinated. The immunisation register will record all 3 doses, but you retain the tick once you've had 2 doses. And so if in the future the data suggests that immunity from the primary course wanes so much that people do really need a 3rd dose to retain that status, that could change. But at the moment, our definition is that once you've had the 2 doses, you're fully vaccinated, and that is enduring that status.
Okay. All right. And just briefly on the border closures, was that you provided that health advice to the government about the risk around countries from Southern Africa? Was that...
Professor Kelly can answer that. He's fortunately back in the room. Yes.
Yes, that's correct, Senator, on Saturday morning.
Okay. And...
the 26th,
Yeah.
27.
And I think you've put that in place until the 15th of December, is it?
That's correct.
Okay. And is that looking like a realistic timetable for you to have the information available to you to make further decisions, or is it looking like you'd have an extension of the 15th of December?
So I provide advice, of course, Senator, I don't make decisions, but the advice that I've been providing has been on a daily basis to Minister Hunt. He, as the Minister for Health, is responsible for making decisions under the Biosecurity Act. That's the legal basis upon which those restrictions are there. So that's an ongoing matter, and I gave more advice to government more broadly on Monday night, and that will continue throughout the week. I think the crucial things, as I said in my opening statement, we will have more information about the laboratory testing of what they call neutralising antibody studies, which is a marker of vaccine effectiveness. Later this week is what we're expecting, and that will be very helpful in that decision making. I have been clear all the way along that I won't have the complete answer about what Omicron is and how it's likely to spread in Australia for some time, and it'll be a matter for government as to whether that information that we will have in place by later this week, early next week, will be enough to change those settings. But for the moment, they're until the 15th.
Okay. So what information will you have by the 15th?
We've got an enormous amount of information that we didn't have last week or the week before, so it's continuing on a daily basis. We'll have locally information on the expanding number of cases in Australia. We'll have very detailed data on those people. We will have by then, I would suspect, 1,500 or more cases around the world, which we'll be able to have at least further information about severity in that case, and ongoing discussions through the WHO, but also directly with South Africa, who has the best data available so far around severity, and some information about vaccine effectiveness at that population level, but it won't be complete information for that. I think the other element, which I think I mentioned earlier, is that there's now almost 50 countries in the world that have reported cases. Many of those have had local transmission. Some of those have exported cases to other parts of the world, within Europe, outside of Europe, from Europe to other places. And so I think that's something that needs to be taken into account. I would like to put on record that I'm very grateful, as we all are, for the openness of the South African government and their researchers and clinicians for sharing this information with the world, and that's very important. I think as it spreads around the world, then the consideration of whether it's reasonable to continue to mark out those countries alone is certainly a difficult decision, and a decision for government, of course, but I'll be giving some advice on that matter as well.
Okay. So your evidence is you'll have some information, but not all the information about Omicron by the 15th, but then it's over, but you will be advising government up to the 15th, and it's for them to make a decision based on the information you have provided them.
That's correct.
It's a bit of a yes minister episode, but yep, okay. You're not going to give me anything more, are you, Professor Kelly, on that one?
It's an important separation of powers, Senator. I think you'd be supportive of that.
Yeah. Okay, and on the, sorry to jump around again, but to Professor Blythe, on the children's vaccination, you're currently working out the interval between the first and second shot. Am I right that I read somewhere that you were considering an 8-week gap, but you're also looking at a shorter gap? I think I've read somewhere. So, I'll ask a question. Is the decision somewhere between 3 and 8 weeks between first and second dose? Is that what's currently before ATAGI?
Yes, we are considering a dose interval between those 2 points.
Right. And I'm not going to get anything more out of that either, I can tell.
Probably not at this stage, but we will be finalising that and providing to government.
Okay. And is part of the consideration around that, so based on what we know to date, that it seems like the 8-week interval is optimal, but in terms of getting kids fully vaccinated, you could look at reducing that time.
So there's a couple of things in there. So the registered time interval is 3 to 6 weeks. There are some benefits of longer intervals, being that one, greater immunogenicity and sort of strength and length of immune protection. There is probably some signal about lower adverse events rate following second doses as well. So both of those things factor into our consideration. Also, because, we are watching what's happening internationally, a slight delay in the second dose will give us more time to watch happening in the international space, because adverse events or side effects are more common after second doses than first doses with the Pfizer vaccine. We've learnt that from our previous experience in adults and adolescents. So all of those factors are being considered to whether we go with the standard or perhaps a longer interval.
Yeah. Okay. So it looks like, term 1 for primary schools will be impacted in some, it'll take until the end of term 1 really to fully vaccinate this population.
Regardless of interval, certainly vaccinations in this age group will be needed to be delivered through term 1 because of the practicality of delivering vaccines to that many children.
Yeah. Okay. Thank you very much, Professor Blythe. I really appreciate you being here for the whole session again, as I do other officials. I'll just check around the room. Senator Davey, do you have any questions? I know Senator Lambie's was a... No?
Yeah, I do.
Oh, I was misreading the hand signals.
I've just a couple of final questions from Professor Skerritt, because we haven't touched on it. I've been hoping we get round to it, but just back on the issue of rapid antigen tests.
Sure.
They're now approved for use in Australia. How many have been approved for sale? And do we know how many have been supplied to date? Have we been tracking that sort of data?
Yes, thanks, Senator, for your question. There's types of rapid antigen tests. There's the ones that have been around for several months that can be used in occupational situations, and they've been used very extensively in aged care. They've been used quite extensively in the construction sector and the transport sector, in the logistics grocery sector, and also in some service industries such as banking. On the 1st of November, so five and a bit weeks ago, the availability of rapid antigen tests as self-tests to individuals commenced. And those tests have been able to be provided online, available at convenience stores, grocery stores, supermarket chains, pharmacies. There's not a constraint on who can supply them. In terms of numbers of different products, there's currently 15 self-tests and about 40, I'll call them point of care or professional tests. In terms of units that have been distributed, there's, as of the 2nd of December, I'm getting very confused with months today. As of the 2nd of December, there's been just under 15.5 million point of care or professional tests, and just under 6.2 million tests that have been sold by the companies and put into the distribution chain. Now, I'm not saying that they're in the hands of every individual. They may be on pharmacy shelves, they may be on their way to supermarkets, but that's if you put that together, that's heading up towards almost a test being sold for every individual in Australia. So there's been tremendous uptake of these testing.
And is there a difference in standard or efficacy between the point of care tests, self-tests?
It's a good question, because with the point of care tests, obviously there is an involvement of a health professional in making sure the sampling is done right, the testing is done right. And those who tend to do those point of care tests tend to be doing them a lot more often. So what we found, whether it was in aged care or whether it was in the distribution sector, there'd be 1 or 2 nominated employees, and they got very good at doing these tests. It's like anything, it's like tennis. If you do it a lot, you get good at it. Well, some of us, I gave up. But So generally those tests, are done. Now, self-tests, of course, have extra tests for making sure the instructions are easy to follow, that it's clear about what it means if a test is done incorrectly. So, but I think being human beings, there will be more human error in self-tests. And so that's why it's a requirement with the self-tests to be able to say that if you have the symptoms, even if you get a negative test, don't just think you've got hay fever or the flu or a cold, go and have a PCR test. And that's a really important message, because you may have mucked up your self-test. Even though we're not hearing of major problems, and there's a requirement of companies to report to us if they hear of a significant number of tests not performing properly. But the message is, if you feel you've got the symptoms, even if your self-test is negative, go and get a confirmatory PCR test just to be sure.
And what's the process if you self-test and you get a positive test?
So again, the advice if you get a positive test is to go straight to a testing centre, preferably one that you can drive through, advise them that you've had a positive test, and again get a PCR test. We haven't heard cases of false positives. We've had a few cases that we've heard of where people were negative, but they came up positive in a PCR test. Now, that could also be timed. So the self-tests aren't as sensitive as a PCR test. So on day one, you could be negative on your self-test, but by the time a few hours sampled for your PCR test at the testing centre, you've got enough virus in you, sadly, that you're now positive. So the message for both is go and get a confirmatory test. Clearly, if you've done a self-test and you may have had a headache or something minor and you're negative, well, that's reassurance. But if you feel you've got all the symptoms, but for some reason you've come out negative, get a check is the message.
I would imagine, are they also good for preempting? So if I'm going going to a function or something, I feel fine, but I just want to make sure my friends are safe, doing a self-test before I go, say, to a wedding, could reassure me.
Yes, Australia hasn't mandated self-tests being used. In some countries, if you want to go to a rock concert or a footy game, they're even getting you to line up and have self-tests. We're not in that world, but there are some businesses, for example, also particularly in home and aged care, where they're saying, well, and it's been taken up quite highly on a voluntary basis for people to go and get tested just to be sure that you're not carrying an infection, because we do know there's also asymptomatic infections, and you won't infect populations at risk, or you won't infect your family and friends. And so, as I say, we've had over 20 million of these tests used, and I think many of them have been used in the way that you've mentioned, Senator.
Great. Thank you. That's all from me. Thanks, Chair.
Thank you very much, Senator Davey. Can I thank officials for your attendance today and for taking a few questions on notice. If you could provide those by the 21st of December as a Christmas present to the committee, we would appreciate it. We also mainly promise not to have another hearing before Christmas. That's your other present.
Excuse me, Senator Gallagher. Can I ask one quick question of the
Thank you
TGA,
so much,
please?
Senator.
The committee stands adjourned. Thank you.
Thank you.
Thanks, Senator.
Thank you.
Thank you.